start my presentations with just some basic terminology. And the reason I do that is that there's a lot of confusion, I think, out there on what terms mean and how we use them interchangeably, but also some of the terminology is important when we talk about reimbursement. So just to start, I will likely use the terms telehealth and telemedicine interchangeably. And most people do, but really telehealth is a broader definition of remote healthcare that doesn't always involve clinical services. So telehealth can include health education, public health interventions, distance health administration, and many other things. Whereas telemedicine is the use of medical information exchanged from one site to another via electronic communications to improve a patient's health status. And there are a variety of different modalities for telemedicine and telehealth. You probably have heard the terms synchronous or real-time audio video interactions. And this can be done with the use of telemedicine peripheral devices like digital stethoscopes, otoscopes, and exam cameras, or can just be through real-time audio video, for example, if you're doing it to the home or to a cell phone. Asynchronous, or store and forward as many people call it, can include video and audio recordings, stored images such as x-rays or pictures of rashes and things like that, online interviews or messaging, sort of the e-visit format as well. And then mHealth or eHealth really refers to anything and everything that can be done from a portable device. So remote patient monitoring, wearable devices, health apps, anything you can do on your cell phone would fall into that mHealth category of telehealth. A couple other important terms. The originating site or the spoke site is the patient location, and the hub site or distant site is the provider location. And again, these things are particularly important when we look at reimbursement for telehealth. And the originating site can be anything from a home, a school, a jail, a nursing home, a clinic, an office, any number of locations, as can the distant site. Telehealth applications really can fall into, I always group them into 4 categories: teleeducation, teleresearch, telepractice, and teleconsultation. And so tonight I'm going to focus more on telepractice, which is really what all of you are likely doing if you've been thrust, as many of you have, into care through video platforms and such during the COVID-19 pandemic. And telepractice really connects a provider to a patient in another location. So again, it can be any number of locations as the originating site. And this can be done either synchronous or asynchronous, or even remote patient monitoring is considered part of telepractice. For nurse practitioners, there's a lot of important information to consider when talking about telehealth. And I'll start with just addressing some key professional practice telehealth related issues for nurse practitioners. It's very important for nurse practitioners to be familiar with a number of legislative and regulatory components. There are many things that affect telehealth at both the federal and the state level. So in addition, things like credentialing and privileging, malpractice, standard of care should all be considered. And I'll highlight a few of these briefly in the short time that we have together. Telehealth policy is impacted by many different federal and state laws, regulations, policies, and government programs pertaining to health. It's important to be aware of more than just telehealth specific legislation. Telehealth providers really should be familiar with one very important piece of federal legislation called the Ryan-Haidt Online Prescribing Consumer Protection Act, as well as CMS legislation and regulation, because this pertains to telehealth reimbursement. And of course, there's a lot of legislation recently in light of the COVID-19 pandemic. So I'm not going to go into great detail about a million different pieces of legislation. We certainly don't have time for that, but I will highlight some very important things for nurse practitioners to be aware of. Be sure to review the information yourself in detail. Things are changing rapidly, sometimes daily, in the telehealth environment. So do, again, go back and think about your own setting and again, just stay abreast of all the changes that are coming, and that as the pandemic moves out, there will be additional changes kind of moving things likely back to the way they used to be. I do want to highlight the Ryan-Haidt Act. This is also known as the Internet Pharmacy Consumer Protection Act. It was passed in 2008 as an attempt to prevent the sale of prescription drugs over the internet without a valid prescription. And it requires at least one in-person visit by a provider before prescribing controlled substances via telehealth. It does allow the prescribing of controlled substances without an in-person visit if the patient is in the physical presence of a provider who holds a DEA or is physically present in a facility that has a DEA. Now, in 2018, the Support for Patients and Communities Act required the DEA to establish a special registration for telemedicine within 1 year of its enactment prior to COVID-19, this hadn't been completed. So it would have been due to be in place by last fall. However, in light of COVID-19, on March 16th, the DEA established that DEA registered practitioners in the United States may issue prescriptions for all Schedule 2 to 5 controlled substances to patients for whom they have not conducted an in-person exam prior to telehealth visit, if certain conditions are met. And this is only authorized during the public health emergency. You can go to the DEA website. There's an infographic. There's a lot more detail and information on this, but the required conditions, the prescription has to be issued for a legitimate medical purpose by a practitioner acting in the usual course of his or her professional practice. Telemedicine communication has to be conducted using audio, video, real-time communications. And we have to be practicing in accordance with all applicable federal and state laws. And there is an exemption for treatment with buprenorphine for opioid addiction. You can use audio only for that, but if that's something that you do in your practice, I'd encourage you to go to the DEA website and read all of the details surrounding that. So let me emphasize the importance of knowing both federal and state legislation as it pertains to telehealth, because even though the DEA modified this temporarily during the COVID-19 pandemic, state laws, that many states have laws that also have restrictions around prescribing controlled substances over telemedicine. So you want to be sure about the laws in your state and if there have been any executive orders changing them during the pandemic, because just because the DEA has changed this requirement, state laws will still prevail. So again, be familiar with the state laws in the place where you practice. And if you practice across state lines, it's very important that you also recognize the legislation and regulation in the state where the patient is. That's of the utmost importance. Legislation and regulation established by CMS, or the Center for Medicare and Medicaid Services, directly affects telehealth reimbursement. And this is important because it often influences what other payers follow. And initially, the telehealth-related regulations were established in the Social Security Act of 1997. And so it was in law. So for many years, we've been advocating for changes and expansion of telehealth reimbursement through CMS, and it's been sort of an uphill battle. But based on the legislation and definitions of telehealth, that is why a lot of the reimbursement was restricted. But in 2018 and 2019, the Bipartisan Budgets Act of 2018 and then the Physician Fee Schedule final rule, they modified what's considered a Medicare telehealth service to allow coverage for what is termed the communication technology-based services. And so this opens some telehealth-related services outside of the traditional telehealth services that were very restrictive within CMS. And I know that most of us don't see Medicare patients as pediatric providers, but these influence the Medicaid regulations as well, which are decided at the state level. So it's important to just know the difference between what's considered a telehealth service and a communication technology-based service, and I'll talk more about that in a minute. Providers must absolutely be familiar with the state laws and regulations in both the state where you practice and the state where the patient is located. It's really important to look at the state laws, not only to identify if there is a telehealth law. If so, what Practice Act does it mend? So is it attached to the Physician Practice Act? Is it a standalone bill? Does it apply to nurse practitioners? Sometimes the verbiage is such that the definitions and things only apply to physicians. In other cases, it can be applied to all healthcare providers in the state. So it's important to read any telehealth legislation carefully. You'll also want to look at Nurse Practice Act, see if there are any specific guidelines or directives from the board in law, but also any advisory opinions, position statements by both the Board of Medicine and the Board of Nursing that pertain to telehealth care, because it's quite varied from state to state. And then also, of course, your Medicaid legislation and regulation. And state laws, as I said, differ significantly from one state to another, but they typically can contain some semblance of the following items. It may contain a clear definition of telehealth or telemedicine or both. They almost always say you must maintain standard of care. They'll include if there's a consent requirement. So some states require a separate telehealth consent. They will specify whether you can see a new patient over telehealth. In other words, whether you can establish a provider-patient relationship through telehealth. They'll include information on requirements related to prescribing, as well as any specific licensure or certification requirements. There are a few states that actually require a telehealth certification or a telehealth license, if you will, to provide telehealth care in their state. Some of those things have been waived in light of COVID-19. So again, it's very state specific. They also will often address cross-state licensing and then reimbursement, such as parity laws. And while there are cross-state licensure compacts for physicians and nurses, physical therapists, and many others, there is not currently an active compact for APRNs. The APRN compact only has 3 states in it so far, and it won't be enacted until there are at least 10. Now, during COVID-19, CMS waived the requirement for providers to be licensed where the patient is located, but that does not supersede state law. And so I think sometimes this is confusing for people. When CMS waived that, it has to do with billing. State laws may still require that the provider be licensed in that state. Now, some states will have issued an executive order to allow cross-state practice. But for example, South Carolina, they have an executive order that allows cross-state practice, but only from our neighboring states of Georgia and North Carolina. And that's because the board perceives that their APRN regulations are very similar to ours, and many patients already cross over state lines because of how close they live to the border. So again, if you're practicing in a practice that is close to a border and your patients are now at home, but they're in another state, you'll want to make sure that you can practice across state lines based on your state regulations and the patient's state. Now, how do you keep track of all these things? Well, the wonderful thing about it is the Center for Connected Health Policy, and the resource for this, there is a link on the COVID-19 page for NAPNAP as well. But the Center for Connected Health Policy is an incredible resource. They follow all of the federal and state legislation, all of the changes related to COVID-19, and every year they put out a telehealth policy manual for all 50 states. Now, they don't follow things like advisory opinions or position statements by boards and things like that, but anything that's in legislation, they follow. You can go and click on your state and find out all of the information at any time, and it's a wonderful service. So I encourage you again to go to the Center for Connected Health Policy for details. Now, telemedicine is definitely an innovative way to deliver care, but it does not change the standard of care. And I always emphasize that it does not change the standard of care. It's just a tool that we use to deliver the care that we already provide. So it's really important as clinicians that we continue to follow evidence-based guidelines for our practice, and that we provide care based on those guidelines. It's absolutely appropriate if you're conducting a telemedicine visit and you don't feel that you can get enough information to make the diagnosis, or your gut is that this child needs further assessment in person, it's appropriate for the provider to redirect the visit to an in-person setting. Now, I always tell people that doesn't mean you just say, oh, I can't do this over telehealth. It's the same way if someone came into your office and you did an assessment and you realize you need to refer them to a specialist or to a surgeon or whomever for additional evaluation. you still are able to help that patient get where they need to be to get the most appropriate care, even though you weren't able to complete the care in that office setting. It's the same thing with telemedicine. If I'm doing a visit and I really feel like, you know what, I'm concerned, I really think this child's, abdominal pain needs to be assessed further, then I'm going to refer them to in-person care, but I'm going to also make sure that the family, knows where to go, that they have a way to access care, do they have a transportation, kind of facilitate things. So you want to be sure that you document well, in addition to that, what the assessment was, what you recommended, and all of the plans that were in place for the patient to get to that location for care. It's also important to be aware of established protocols and guidelines for telemedicine. The American Telemedicine Association has quite a few guidelines on their site. Now, you do have to be a member to access the guidelines, but there are quite a few different guidelines on there. There is one specific to pediatric care that is endorsed by NAPNAP and the American Academy of Pediatrics. I will say it's a very broad guideline, and I happen to work closely with the team that developed it. And the reason it's broad is because, again, it's the same care we provide every day. Telehealth doesn't change our standard of care. So I often get questions about, was there a list of conditions we can see or we shouldn't see or we should? And my answer is always, you get an extensive history the way you would in person. You make that clinical judgment. You get as much physical information as you can. You may have to ask the patient, if you're doing a visit to the home, for example, can you weigh the child? Can you take their temperature? Just kind of getting a little bit creative. If they're having a tummy ache, have the child jump up and down if they're old enough to see if they have, double over in pain when they try to jump. So you can get creative with the exam to get enough information to make a clinical judgment, and just make sure to document thoroughly, all of the assessment that you've completed. So again, being aware of guidelines that are out there, looking at expert opinions. If you're in a specific specialty, most governing bodies have position statements or recommendations for care. So be aware of those for your particular specialty as well. I always like to mention malpractice as well. It's important that you check with your malpractice company to make sure that it covers telehealth. Some do, some don't. Some charge an extra cost. Some require a separate rider to be purchased. You want to ask, if you do provide care across state lines, does the malpractice extend beyond state lines as well? For those of you that might work in FQHCs or other RHCs and things of that nature, the FTCA, or the Federal Tort Claims Act, doesn't view telehealth as a different kind of care. Generally, they do, the FTCA, that is the kind of coverage, so to speak, that employees in those facilities have. If the care is provided within the scope of care on that facility, then it is included within that. But it's always recommended to consult HRSA and the representative for your particular clinic to make sure that everything is in order, so that it falls within those guidelines. And some recommend considering additional cyber liability coverage to protect against things like data breaches or hacking. So I'm going to talk just a little bit about telehealth reimbursement as we move into some of the COVID-19 changes. First, it's important to note that there are parity laws. So there's a couple different kinds. Parity laws definitely vary by state, and not every state has a parity law. Coverage parity refers to policies that prohibit payers from excluding a covered health service from coverage solely because it's delivered via telehealth rather than in person. But payment parity refers to a policy that requires payers to reimburse for telehealth services at the same rate as those services when they're delivered in person. And so states may have parity laws both for Medicaid and private payer reimbursement, or they may not have any parity laws at all. Coverage and reimbursement for telehealth is based on a lot of different factors. First, the payer or plan may have a blanket policy about telehealth coverage, whether they do or they don't cover it. It can be based on specialty type, the particular CPT codes that are used, the distant site provider type. At least prior to COVID-19, there were some private payers that only reimburse physicians for telehealth care. And that has expanded quite a bit. But again, distant site provider type can play into whether it's reimbursed, as well as the originating site type and location. Whether there's a telepresenter involved or not can affect reimbursement. And then of course the type of telehealth, you know, whether it's asynchronous or synchronous or an mHealth modality. The state Medicaid is decided at the state level. And as of fall of 19, 50 states reimburse for live video, 14 states provide a reimbursement for store and forward, 22 provided reimbursement for some form of remote patient monitoring. 6 states required geographic restrictions. 23 states limited the type of facility that can serve as an originating site. And 19 states allow reimbursement for service to the home. Now, a lot of that has changed since COVID-19. It's unclear how much will go back to restricted once the pandemic is over, but it's definitely something to watch. The code category for telehealth is based on the location of the patient. So the decision between inpatient or outpatient E&M code is based on where the patient is located at the time of the service. Now, most payers require you to add a modifier. Usually it's a GT modifier if it's synchronous care. And you would add the usual CPT code and then add this modifier. Medicare, again, I know we don't often bill Medicare for our services, but Medicare requires a 95 modifier. And then there are different types of modifiers for other types of telehealth care and that type of thing. The place of service code for telehealth services is 02. Now, many of you may or may not be aware that depending on the location of the service, like in a clinic, there's the place of service 11, in a school it's 03. So telehealth is 02. However, certain services fall under the communication technology-based services that I mentioned earlier that have to do with like the virtual check-ins and the phone calls. And in that case, you wouldn't use the place of service 02. So it's a little bit complicated, and I live and breathe this stuff, and sometimes I still get confused. But the bottom line is you want to make sure that you're coding correctly based on what the particular payer your patient population requires, and also billing the maximum you can, meeting the requirements for the maximum code that you can bill to get reimbursed. There are specific codes for e-visits or asynchronous visits. There are virtual check-in codes that can be done by audio or just through video. Now, the virtual check-in codes are, they pay a little bit less, like $10 to $15, versus if you were doing a 99213 visit, but did it over video or audio. If you can meet the criteria for that particular payer or that state Medicaid plan, for example, it's better to bill the regular outpatient office code with the video modifier than to do the virtual check-in or the audio only code. So a couple highlights in addition that have evolved in light of COVID-19. So when CMS made the changes, there are things that the telehealth community has been really seeking for many, many years. So we're really hoping that a lot of these things stay in place and continue to influence private payers and state Medicaid plans as well. But one of the key things is really taking away the geographic limitations. So prior to this, for Medicare in particular, the originating site had to fall within a specific zip code within a healthcare shortage area. Now they've taken away all of the geographic restrictions, and they have also allowed home as an originating site, which is really huge because prior to this, it was not considered a valid originating site for billing purposes. They've expanded the eligible providers. Now it's not just physicians, nurse practitioners, physician assistants. They've really extended it beyond that to physical therapists, occupational therapists, speech pathologists, social workers, dietitians, and so on. They've also allowed payment to be the same rate as in-person visits again for Medicare, but many state Medicaid plans have followed suit in this, even if it's just temporarily. Many private insurers have announced that they will make telehealth more widely available and have agreed to cover services even in states where there isn't a parity law. Another kind of hot topic, I guess you'd say, with regard to COVID changes is the fact that FaceTime and Skype and those types of platforms that are not considered HIPAA compliant are able to be used during this pandemic for care. And it's really best practice to use a connecting platform that is HIPAA compliant and secure for many, many reasons. But the reason where this information came from is that the Health and Human Services Office for Civil Rights stated that it will exercise discretion and waive penalties for HIPAA violations against healthcare workers doing appropriate care in good faith using these types of technologies. Now, they definitely said that you can't use a public-facing platform, you know, like a TikTok or Facebook Live or something like that. But many states have laws that say you have to use a HIPAA-compliant secure platform. So just because HHS has said that they are going to not prosecute people for using things like FaceTime or Skype, you still have to make sure that the state you practice in, that the law allows that, because many states have not waived that. CMS also clarified that telehealth services are required to be multimedia communications with audio and video. And then just this week, they added, I think it was April 30th actually, CMS added telephone as a telehealth modality for some very specific codes that they traditionally required had to be done via video. And on the Center for Connected Health Policy website, you can find all of these details, and they actually have a link to the list of codes, and it'll say whether it can be done over video or audio and that type of thing. And it's also been the case that they've raised the reimbursement rates for audio or telephone visits as well. And there are some specific telephone codes that have been added. Some are particular for physicians, NPs, or PAs, the 99441 and 99443. Those are time-based codes that can be audio only. There's also the virtual check-ins, which I've mentioned before. They're G2010 and G2012. Now, those have been around for a little while. The difference is that now you can use them for new patients as well, and they can be synchronous or asynchronous. You can do it over the phone, but it can't be a result of a visit that happened within the prior 7 days, or you can't bill it if the patient ends up coming for a visit within the next 24 hours following. And these only pay about $10 to $15. So some Medicaid plans and insurers have allowed audio where they used to require video. And if you can meet certain criteria, you can, again, go ahead and bill that 99213 or the appropriate outpatient code, and the reimbursement will be higher. So you really want to look at in your state what changes, what the status was before COVID and what changes are in place, so that you know you're billing the most appropriate code, meeting the appropriate criteria to get the most benefit from that reimbursement. And then at the state level, most states, and many states I should say, expanded the list of eligible providers to include more allied health professionals. Some again have allowed cross-state practice, but some have very specific guidelines on that. Some have waived consent requirements, so they'll allow verbal consent when it used to say it had to be written consent. Some will allow consents to last longer. If they used to say you had to have one every year or every visit, they may allow it to be one consent per year. So there are a lot of details that may have changed as a result of the COVID legislation and executive orders by state. Okay, so I know that's a ton of information. Just wanted to try to give you sort of the telehealth landscape and what is happening and continues to happen on a very rapid pace within the world of telehealth. But I'm happy to open it up for questions if anyone has anything specific you'd like to ask.
Wonderful, Kelly. Thank you so very much. And so just to let folks know, right now you're all muted, but I'm going to go ahead and unmute you. If you'd like to, perhaps if you are on the computer and can enter your name into the chat box, I can call on people so we don't have that talking over thing. And I know we have a few people on the phone, so we'll also call and for them to share questions or ask questions as well. But we did have one question come in earlier. Kelly, you mentioned a group, perhaps you mentioned the Center for Connected Health Policy, but then did you mention another group like American Telemedicine site that had some resources?
Yes.
And if so, can you rename that for everybody?
Yes, thank you. It's the American Telemedicine Association, and it's probably one of the longest standing telemedicine associations out there. Sort of before telehealth was very popular, it was a grassroots advocacy. But they do have a lot of guidelines that you can find. They have a lot of resources as well. And it's a great way to connect with other people doing telehealth.
Excellent. Alrighty. And so again, if there are any questions, feel free to type your name in the chat box, or if you can just share your question with us. And remember, everyone's unmuted, so we are hearing background noise if from your home if you're in a noisy area. Any questions?
This is Karen Duderstadt, and thank you, Kelly, for your presentation. It's really great. Hope everybody can hear me. Yes?
Yes.
Okay, well, I just want to say, and this is a broad question, so it may be for a broader discussion, but there's been, with these major changes, and you talked about it in terms of COVID-19 and the pandemic, there's been so much concern from pediatric practices, particularly in smaller areas and rural areas, just about the loss of income during this time from primary care, which is usually what sustains offices. And I think all of us believe this is going to continue for a while, and the social distancing. So I just wondered if you had a thought, or if anyone did, about the issue of, will telehealth fill this gap for us in states that step up and make a change in policy?
Sure. I think it definitely will. The American Academy of Pediatrics, as well as I represent NAPNAP with the section on telehealth care executive committee, and so the AAP, and they're very much aware of what's happening in pediatric practices, and of course that affects us as well as pediatric nurse practitioners. And so they are doing a lot with advocacy, as is NAPNAP on the national level, and really trying to protect that pediatric medical home, both financially and in terms of making sure kids get the appropriate care that they need. But telehealth can certainly be used. Many practices have converted visits to telehealth. They may have, some are doing like doing as much of the visit as you can, say for a well child visit, do most of it over video, and then have set days or one set office that's only for well visits, and they come in and just get their shots and go out. So I think there's a lot of ways to be creative and really use telehealth to get those volumes back up. And that's why I kept mentioning about making sure that the reimbursement, that you're coding properly. Typically, and again, I work at a center for telehealth that is one of 2 national centers of telehealth excellence. So we live and breathe this all the time. But for us to develop a telehealth program, it usually takes about 3 to 6 months, because we're looking at, who the originating site participants are, where they are, who the providers are, privileging, credentialing, training, making sure that the billing is in place. Is this service even billable for the particular payers that are involved in that particular practice? But with COVID-19, everybody just kind of ran full steam ahead and like, okay, convert everything to video. But now I think people are realizing they have to think this through a little more thoroughly. So I definitely think telehealth will make a difference. It already has, and it will continue. But I think practices have to be really wise about it and really get educated on the appropriate ways to bill, how to maximize the exam, how to communicate. I've talked to a number of our members that have reached out to me that they've switched to video, but they don't know how to get the patients to use it. So, how do you market it to your patients? There's so much that really can go into sustaining a telehealth program. And if all the pieces are in place, it's amazing. But if that's not well thought through, I would share your concern that it may not get as much use as it could.
Thanks, Kelly. Do we have any other questions from the group? Kelly, one question that we had received just we're talking about this call tonight. A member had asked, what can we do at the state level, chapter state level, to make these telehealth changes that have been spurred by COVID and governor's emergency orders? How can we advocate to get those telehealth changes to be made permanent? Do you have any recommendations on that? Like, what is it going to take?
Sure. I think that it's always helpful to band together, if you will. Here in South Carolina, we have what's called the South Carolina Telehealth Alliance. And so that's an organization, not even an organization, it's a group of representatives from all across the state, from the major medical institutions and private practices and politicians and many others that come together to advocate and to work on telehealth initiatives within the state. So I think reaching out to your representatives, but also, coming together, if you can come together as a group and have a louder voice, I think that always makes a difference. Excellent.
Great. Thank you, Kelly. And we have a question from Sarah out in LA, and she's asking, are there any recommendations for using interpreters with telehealth? This has been a challenge for her practice.
Sure. Honestly, I don't know if there's any official sort of guidelines or recommendations out there. I've not seen any in publications, but I will say at our facility, we use the same interpreter service that one would use for in-person care. I primarily practice in school-based programs, and so sometimes you have to get a little creative depending on, whether you want them to be on the phone that's on your end of the visit, or whether, in our case, at the school end where the nurse and the student is. But typically we just get them on the phone and join them in the visit like we would in person. It just happens to be through a telephone call, or one of our platforms you can join multiple people into the connection. So we have done that before as well.
Fantastic. Thank you. Other questions from the group for Kelly?
Hi, Kelly. It's Raji. How are you?
Hi, Raji.
Good to hear you. Thank you so much for your expertise in sharing this with our members. I wanted to ask a quick question about phone calls, which I know you spoke to. As you know, I'm in California, and we now have some changes at our institution around when a telehealth visit is initiated, but something breaks down with the technology and you have to convert it to a phone call. You can still bill for it and account for it in a certain way intended as a video visit and get reimbursed for that. But certainly I know there are a lot of advanced practice nurses on the front line who have to rely on phone calls alone to provide certain amounts of care if families don't have access to the telehealth technology from home or wherever they may be, and opportunities to advocate for the phone call reimbursement that's part of a lot of the complex care coordination for certain practices. If you could comment on that.
Sure. Yeah, we've faced that a little bit. A lot of the families we serve through our school-based program live in very rural and very poor literacy and poor health literacy. And what do they call it, like the digital divide, where there isn't even, access to internet or cell service sometimes in their areas. And so we've found that in some cases we're having to convert video visits to the home to phone calls. And again, it depends on your state. Again, the clients we serve in this case are often Medicaid, and in our case, Medicaid will reimburse it consistent with the video visit right now. Wasn't necessarily the case before. So it's one of those things where I think you have to know your state and your payer group and make sure that you are documenting appropriately, because again, some states have said, well, you can do the same visit that you would have done through video through phone, and we'll pay it the same, and it's all good as long as you document the time. Some will not do that. Some specifically, you have to use the telephone code, and then that's a time-based code which pays less. So I think the biggest thing I would say is to make sure that, depending on the state everyone's in, just make sure what is appropriate where you are, and then bill it accordingly, because it's too hard, honestly, to make a blanket statement because it does vary so much.
Thank you. Other questions for Kelly this evening?
Hi, this is Sarah. I had another question, just thought it may be easier than putting in the chat. When we were at our hospital, like in the beginning, we were told, when we were transitioning over with COVID, to do as many telehealth visits as possible. And then over time, we've kind of been told to go back to, only doing it, if there is really no other option for the patient coming in. Like if I work in an oncology practice, but, if the patient's coming in for other things, obviously to have them come in and group those other imaging or lab studies and things when they're there to see them in person. But we were told, and this may be a state-based issue as well, but that the reimbursement was not as good. And so I'm just wondering, is that probably where you're saying there's a state, issue in terms of it not being parity equal
Yes.
for, the reimbursement?
Yes, definitely. And depending on, if your client population is more private payers and those private payers don't, so again, some private payers really are very limited in the coverage, and depending on the state you're in, like Medicaid or Medicare may reimburse better for telehealth. But it's likely the case that they, depending on the, again, hospital-based services, and then sometimes there's that facility fee that people get.
Right.
So there's those things to factor in too. So when you're talking about inpatient and hospital-based versus an outpatient clinic, there are other factors that you might lose reimbursement, especially state by state. It may vary as well. I know that's kind of a vague answer, but it's such a complicated thing. But it's likely that they were not getting some of the additional reimbursement that would normally be received if the patient comes in person.
Thank you so much for being with us this evening, Kelli. You also did our Facebook Live to the public about telehealth a few weeks ago, and both have been very well received. So thank you so much for your expertise and sharing it with all of us here at NAPNAP, all of our members and followers.
Well, thank you so much for having me. I always appreciate the invitation. It's a pleasure.